Hi everyone. I'm going to be trying to do a new video series where I will be doing internal medicine questions, and I'm going to try my best to upload at least a couple of times a week. And I'm going to try to keep these videos as short as possible. Each video, my goal is to make it less than 4 minutes because I know we all have limited time on our hands. So the first question, we have a 44-year-old man with ankylosing spondylitis who has had intermittent diarrhea, abdominal pain, weight loss, 7 kilograms, and low-grade fevers over 6 months. Exam reveals left lower quadrant tenderness and high monocyte count on blood smear. Labs show leukocytes of 10,500, MCV 85, hemoglobin 12.1, platelets 425,000, monocytes 18%. The absolute count is 1,850. The question asks which test would confirm the diagnosis. Answer choice A, measurement of ESR. Answer choice B, EGD. Answer choice C, colonoscopy. And answer choice D, bone marrow biopsy. So if you go to the next slide, we have monocytosis and its causes. So the patient that we have in the question stem, he has monocytosis. His monocytes are elevated at 18%. His absolute count is elevated at 1850. So monocytosis, which is the elevation of the monocyte count, can be either secondary or primary. Primary monocytosis is typically associated with bone marrow disorders such as leukemias, and secondary monocytosis is usually due to chronic infections, autoimmune or inflammatory conditions, like lupus or inflammatory bowel disease, granulomatous disease like sarcoidosis, or certain cancers like Hodgkin disease. So if you go back to the question, this patient has ankylosing spondylitis, which is an autoimmune condition. He also has symptoms that suggest a chronic inflammatory process. He has diarrhea, abdominal pain, weight loss, and low-grade fevers. These symptoms and his history make inflammatory bowel disease a strong possibility. Both Crohn's and ulcerative colitis are autoimmune diseases known to cause reactive monocytosis as part of the body's inflammatory response. And as a result of that, colonoscopy will be the best next step. And the reason for that is a colonoscopy would allow us to directly visualize the colon and terminal ileum. And during a colonoscopy, biopsies can be taken, which can help us confirm the diagnosis of inflammatory bowel disease by showing inflammation or granulomas. And if the colonoscopy does not reveal signs of inflammatory bowel disease, we can do a CT scan to look for other potential causes or areas of inflammation that were not seen with colonoscopy. The distractor in this question was the bone marrow biopsy. That would not be the next best step because it would be too invasive and unnecessary at this stage. Because we first need to exclude more likely and relevant reactive causes of monocytosis, like inflammatory bowel disease. So, in summary, the elevated monocyte count combined with the patient's symptoms and medical history raised suspicion for an inflammatory bowel disease, and colonoscopy with biopsy would be the best next step to confirm this.